Across Indian families, there is a persistent debate about which delivery method is easier to recover from. Often, this results in unfair judgments placed on the new mother by those around her. Some older relatives assume a vaginal delivery means a woman should be back on her feet instantly. Others view a cesarean section as an easy way out that leaves a woman permanently weakened. Both perspectives are medically inaccurate. Childbirth is a massive physiological event. Regardless of how your baby is born, your body requires a strict 6-week or 40-day recovery period. To navigate this safely, you and your family must abandon one-size-fits-all traditional rules and understand exactly what the body is trying to rebuild internally. The internal recovery process is severe for every mother. The moment your placenta detaches, your uterus is an exposed internal wound roughly the size of a dinner plate. This line graph tracks the rapid drop in uterine muscle weight as it undergoes a process called involution. Over the 6-week postpartum window, the muscle shrinks from a weight of roughly 1 kilogram at day 0 down to exactly 50 grams at week 6. This shrinking is powered by afterpains, intense uterine cramps triggered by the hormone oxytocin. You will feel these sharp, sudden pains most intensely while breastfeeding during the first week. At the same time, your body sheds the thickened uterine lining that supported your baby. A dangerous myth exists that women who undergo cesarean sections do not bleed afterward. This is entirely false. Every mother experiences this bleeding, known as Lochia. Even though a surgeon swabs out the uterine cavity during a cesarean, the underlying raw tissue still takes up to 42 days to regenerate. Over this precise 42-day timeline, your Lochia will transition from bright red in the first few days to pinkish brown and finally to a yellowish-white discharge. You must monitor this bleeding with absolute precision. Soaking through more than one large maternity pad per hour for 2 consecutive hours is the exact red flag for a secondary postpartum hemorrhage. It means your uterine muscle has failed to contract properly, putting you at risk of severe, life-threatening blood loss. This internal wound regeneration cannot be bypassed by any surgical method. Monitoring your bleeding precisely is a matter of life or death. If you delivered vaginally, the physiological trauma of your birth is concentrated entirely in your pelvic floor and your perineum, the area of skin and muscle between the vagina and the anus. During pushing, these perineal tissues stretch up to 300% of their normal capacity. In many cases, you will have an episiotomy, a surgical cut to help deliver the baby, or a natural tear that requires stitches. This creates an incredibly challenging healing environment. You have to sit directly on this area, and the stitches are constantly exposed to moisture from lochia and urine. In traditional Indian homes, elders often advise sitting over hot coals sprinkled with herbs, or pouring very hot water directly over the vaginal area to dry out the stitches. The clinical reality is that exposing fresh perineal wounds to unsterilized smoke or excessively hot water introduces dangerous bacteria, causes severe tissue inflammation, and delays your healing by weeks. The clinical standard for perineal care is strict but simple. Keep the area clean with warm water from a sterile spray bottle, gently pat it dry from front to back, and change your maternity pads every 4 to 6 hours to prevent bacterial overgrowth. The defining characteristic of your recovery is mobility. Walking within hours of delivery promotes blood circulation and helps reduce swelling in your perineum. When passing urine, pour a steady stream of lukewarm water over your vulva. This dilutes the urine on contact and completely neutralizes the stinging acidity on the microscopic abrasions around your urethra. Because your pelvic floor muscles act as a stretched hammock supporting your bladder and uterus, you may experience temporary urine leakage when coughing or laughing. You face a strict deadline here. Delaying pelvic floor rehabilitation, specifically Kegel exercises, beyond the 2nd week leaves these muscles permanently weakened. Vaginal recovery relies entirely on active mobility and meticulous hygiene. Failing to actively rehabilitate the pelvic floor significantly increases your risk of a prolapsed uterus later in life. If you delivered via cesarean section, your recovery is entirely different. You have bypassed the trauma to the pelvic floor, but you have undergone a major abdominal surgery. This anatomical cross-section reveals the exact depth and true severity of the surgery. To deliver your baby, your obstetrician had to cut through 7 distinct anatomical layers: the skin, the subcutaneous fat, the fascia, the separation of the rectus abdominal muscles, the peritoneum, the uterine wall, and finally the amniotic sac. At the 10-day mark, your skin incision will likely look fully closed and dry. This is a dangerous illusion. As highlighted here, the deep fascia, the tough connective tissue holding your abdominal muscles together, takes a minimum of 6 to 8 weeks to regain just 80% of its original tensile strength. This dictates the absolute lifting rule for your recovery. Lifting any object heavier than your 3.5-kilogram newborn before the full 6-week mark is strictly prohibited. Breaking this rule has severe physical consequences. Excessive intra-abdominal pressure physically pushes your internal tissues through the ruptured, healing fascia. This causes an incisional hernia, a condition that requires a second major surgery to fix. You must make mandatory movement modifications. Rather than using your stomach muscles to sit straight up, you must roll onto your side and use your arms to push yourself out of bed. And you must rely entirely on your partner or family members to hand the baby to you for feeding. Cesarean healing is a deep structural waiting game. Prioritizing superficial healing over your deep tissue limits guarantees severe physical setbacks. During the traditional Indian postpartum confinement period, known as japa or balantpan, the new mother is immediately given heavy, ghee-laden foods like panjiri, dink laddus, and concentrated dry fruit mixtures. The cultural belief is that these calorie-dense foods instantly rebuild lost strength. Your digestive capabilities dictate whether this is safe. A mother recovering from a vaginal delivery returns to normal relatively quickly and can tolerate these foods in moderation while walking frequently. But a cesarean mother's digestive tract has been physically handled and temporarily paralyzed by anesthesia, a condition called postoperative ileus. Her bowels are profoundly sluggish. Feeding a post-cesarean mother heavy ghee and dense laddus in the first 2 weeks traps immense amounts of gas in her stagnant intestines. This trapped gas expands, pushing violently outward against the fresh, painful uterine and abdominal incisions. The secondary risk is severe constipation. Combining these low-fiber traditional sweets with drinking less than 3 liters of water daily guarantees a hard bowel movement. Having a hard bowel movement forces you to strain on the toilet, a physical action that directly threatens to tear your internal surgical sutures. The clinical dietary priority for your body, regardless of your delivery method, is hydration and high-quality proteins, found in fresh eggs, cuts of lean meats, lentils, and fresh paneer. These proteins are required to synthesize collagen, the microscopic building block needed to knit your torn perineal tissues or sliced abdominal layers back together. Applying a traditional, calorie-dense vaginal recovery diet to a paralyzed post-surgical digestive tract actively jeopardizes the mother's healing. Finally, we must address the final pillar of traditional Indian confinement, the mandate for complete bed rest for 40 days, which sometimes discourages the mother from even walking around the house. This generated video shows exactly why prolonged immobility is dangerous. Pregnancy alters your blood chemistry, making your blood naturally thicker and more prone to clotting to prevent you from bleeding to death during birth. This thickened, heavily clot-prone state persists for many weeks after delivery. Lying flat continuously allows this thickened blood to pool in your lower legs. This pooling creates the perfect environment for a deep vein thrombosis, a massive blood clot in your calf that can break off and travel instantly to your lungs, causing a fatal pulmonary embolism. Because of this, there is a non-negotiable movement rule for both delivery types. You must get out of bed and walk slowly around your room for 5 to 10 minutes every few hours. This gentle, consistent movement acts as a mechanical pump in your calves, actively forcing the blood back up to your heart. Rest is vital, but absolute immobilization transforms the postpartum bed into a life-threatening hazard. Your body is remarkably efficient at healing, but family caregivers must remain vigilant for specific signs that the physiological repair process has failed. This checklist outlines the specific postpartum emergency red flags. A maternal temperature rising above 100.4 degrees Fahrenheit, or 38 degrees Celsius, is the exact threshold for a systemic infection. It requires immediate intravenous antibiotics to prevent sepsis. Localized infections have distinct markers. Seek immediate care if your Lochia suddenly develops a rotting odor, or if your cesarean incision begins leaking green or yellow pus. The markers for a blood clot are sudden, sharp chest pain accompanied by extreme shortness of breath, or a single calf that becomes red, swollen, and hot to the touch. Navigating the 40-day period successfully requires moving past the myth of an easier delivery. Instead, you must precisely match the mother's diet, mobility, and hygiene to the exact physiological demands of how her baby was born.